Welcome, everybody. My name is Kenny Miller. I'm a clinical educator. I've been a respiratory therapist for almost 50 years now, and I've primarily worked in the critical care area, but I've had a lot of interactions with the asthmatic patient population. I am an asthma educator, been an asthma educator for about a decade now. So one of the things we're going to talk about today is the educational strategies for the asthmatic patient population, because really one of the big points that you really need to get across to these patients that have asthma is that asthma is a chronic inflammatory disease process. And even when the patient is asymptomatic, that does not mean they don't have the disease. And one of the problems that we run into with the asthmatic patient population, um, majority of the time, some of these asthmatics can have absolutely no symptoms at all. So trying to, get them to administer daily controller medications like inhaled corticosteroids can be quite challenging. And then for those patients that are symptomatic every day, they have uncontrolled asthma or refractory asthma. You need to convince them to take a whole gamut of medications, a whole plethora of medications in order to get their asthma somewhat controlled. So what we're going to talk about today is the educational strategies to try to help these patients, one, understand their disease, two, understand the importance of using the appropriate medications in the appropriate way. Our learning objectives today are going to describe barriers to understand the disease process of asthma, define learning strategies to address learning deficiencies, and review outcome measures germane to asthma outcomes. So this is what we're going to be looking at today in this presentation. So to start out with, the prevalence of asthma in the United States, it's a very common disease. It equals 1 out of 13 people, nearly 26 million people in the United States. And most of those individuals, almost 90%, are over the age of 18. And one thing you have to understand that even though asthma is at this point a very controlled type of disease in a lot of ways, there's a lot of people that have asthma that are very controlled in the terms that they function very well in society. I mean, I have asthma. Just recently missed my first day of work since 2016, and that was because I actually fell and broke a rib. So even though I have asthma, am fairly, very healthy and productive. But every year there's about 10 million outpatient visits, a 500,000 hospitalization, and those patients who do get admitted for asthma can be hospitalized for an average of about 3 days. Some patients go on to get really sick and require mechanical ventilation and even VV ECMO for asthma. And but that's a small percentage. Nearly 44% of asthma hospitalizations are for children, and it's the third cause in hospitalization for children. So even though more adults have asthma, it seems to have a higher mortality and morbidity in the children's patient population. On an average, and this is always very, eye-opening to me, that on an average, 10 people in the United States die from asthma each day. And in 2021, 3,517 patients died from asthma. So even though asthma, as I said, we believe we should be able to control asthma, and asthma should not lead into fatalities. It does. Okay, I've seen over the course of a few years, I've seen some patients die of asthma. It's very scary. It's very unfortunate, and it should be very preventable. So we'll talk about, why does that happen? Why do people die from asthma? So when you look at asthma by age groups, you kind of look again at the number of people at percentages. 0 to 4 makes up 2%. Over the age of 65 makes 8%. And you kind of look at this, and there's a fairly good equal distribution. It seems that really from the age of 17 to the age of 24 seems to be the largest. If we had a bell-shaped curve, that's where the largest percentage of people would reside. That's where, the middle of the bell would be. But you can see it's a fairly equal distribution. It might be 0 to 4, it might be low because it's underdiagnosed, and there may be a gamut of problems these patients have. Asthma may be one of many modalities that and comorbidities that these young children have, especially if they're prematurely born, or they have low birth weight, or they had to be on mechanical ventilation at this point. So that's why that number may be unrepresented, unreported, The barriers to asthma, we look at diversity and we kind of think, all right, what are some of the barriers in asthma? There's a diversity of age groups. There's a wide spectrum of educational levels, access to educational resources, and daily lack of, daily symptoms and confusion regarding medication devices. And one of the biggest drawbacks is there is a big fear of the patient population, asthmatic population, to think about using steroids, even inhaled corticosteroids, which are the actual level 1 daily maintenance drug on the GINA criteria on daily prevention. So the diversity of age groups, what are we talking about? We're talking about the youngest patients to the most elderly. Wide spectrum of educational levels. Again, preschool to everywhere, of being unfortunately ignorant to education, not being able to understand English language, not being able to read, not being able to really interact with the environment or understand what's being said. Educational resources. Again, there's a very good presentation that Terry does that talks about the inequities of asthma, that there's many individuals that don't have the ability to even get educational resources. And then again, I talked about the lack of daily symptoms, and there's a plethora of asthma medications and devices to deliver them. So when you're looking at learning strategies to enhance asthma education, there are 4 essential components of management care in the sense of asthma management. One is patient education. They have to become knowledgeable about their disease. You really need to understand, you'll get it across to them, and it'll be like a broken record during this presentation, that this is a chronic inflammatory disease where there are many asymptomatic days. And being able to recognize, changes in breathing and having an asthma action plan is very, very important. Minimizing exposure to asthmatic triggers. Trying to, pinpoint down what are the triggers for this asthmatic individual and how can we minimize interactions with the triggers. That may be very difficult for someone who lives in an urban area that has triggers. The triggers are cockroaches, air pollution, smoke, secondhand smoke, crowded environments. Sometimes it's easy to say, well, avoid this or avoid this. Try to tell a 5-year-old that they have to get rid of their loved pet because it's causing them to have asthma. That's going to be very, very difficult. But trying to first understand what are the triggers, recognize those triggers, and limit those triggers to the best you can is very, very important. Monitoring changes in symptoms or lung function. It is critical that all asthmatics have some kind of asthma action plan where they know where their normal levels are. May it be peak expiratory flow, how do they feel breathing, how do they feel after exercise, how do they sleep, and also know when the levels are escalating. When you go from a green level to a caution level, what are the symptoms? What are your steps? What is the patient's steps? So maybe in the green step, it's to maintain, the drugs. In the red step, it is that in order to get immediate medical care. So again, having a action plan that looks at how am I doing well, when should I get concerned, and when do I have to really have intervention. And they should get at least, periodic provider visits and periodic pulmonary function studies to look at their FEV1s and their mid-expiratory flows and their peak expiratory flows. And then pharmacological therapy. They need to understand, one, what do the drugs do? Two, what is the goal of the drug? Okay, what is the clinical indication and the clinical effectiveness of the drug? And then three, is what are the side effects? What to look for if you take a drug? Does it going to make your tachycardic? Are you going to be nauseated? Are you going to cough? What is the side effect of those drugs? And then understand how those drugs are administered, because again, there is a whole cornucopia of different ways of administering. There's MDIs, there's nebulizers, there's discus, okay, meter dose inhalers. There are, these spin turbo inhalers. So they really need to understand, and it's important too, that we as clinicians that are educating these patients, make sure that we match the right devices to the patient. I tell you the story of my mother. She was being discharged at a hospital, very confused, very arthritic hands, and they gave her an MDI to give the drug. And my point was that there is no way that she could possibly, one, understand how to use it, and two, physically understand, physically be able to do it. So it's very important that we as respiratory therapists make sure that we're matching up the medications, and nurses too at the bedside. Nurses are very integral with this also, but nurses and respiratory therapists or pharmacists, who's ever working with the patient, really matches, one, the medication to the patient, two, the device to the patient. It's very, very important if you're going to have any success and optimize outcomes. So when you look at asthma self-management, because 99.9% of the time, the asthmatic is going to be either with their family or alone. They're not going to be in a hospital setting, and they're not going to have a clinician assessing them. So they have to, again, understand the pathophysiology associated with asthma and breathing. They need to understand terms they understand. Obviously, you can't be pedantic and use very, very sophisticated terms if the individual does not have that type of knowledge base. And that's why I'm saying diversity of learners is very, very important. You'll know who you're teaching, okay? Know the asthma symptoms and keep track of them. Every asthmatic should have some form of an asthma diary where they actually know what are the triggers. What are some of the other types of factors that can cause asthma? All right, how do you know your asthma symptoms are getting better? How are they getting worse? When should you call your provider? Again, improving communication skills with healthcare providers. There should be some two-way conduit that allows both the patient to interact with the clinical staff to make sure that there's a two-way communication gauntlet, that they should be able to, at any time, if they need to, be able to interact. May it be telemedicine, may it be online medicine, may it be being able to get to an urgent care or an emergency room, but there needs to be some way of understanding, being able to communicate with healthcare providers so we can keep track of the patient's progression or escalation. Learn about asthma medications and take them correctly. I've talked about it once or twice. Again, making sure they understand the medications. This is what opens up my airways. This is what reduces inflammation. You need to put it in terms that they understand, okay? Not in terms that you want to sound smart, okay? Put it in terms they understand. And then make changes in your life to prevent asthma problems, okay? Make sure that, if there's certain things that are going to cause triggers or asthma attacks, may they be acute or leading to chronic. Like, for example, if you know that you're going to be out when someone's mowing the lawn and grass bothers you, wear a mask. Try to, if you're going to go to a social setting and there's going to be people smoking, make sure you take the steps to prevent being in interaction with people, or make sure that maybe there's an option for an outside venue. So these are things that you need to discuss with the asthmatic, and the asthmatic themselves need to have ownership with it. The management of asthma is a cooperative co-ownership endeavor. Both parties need to be able to, one, be responsible, and two, to be communicating, and three, taking steps to improve outcomes. So it's not a, it's all patient or all clinician. It has to be a marriage in the sense that both have to be very, very interactive. And again, these are going to be difficult decisions. As I said, if if your child loves that pet, and one of the changes has to be they have to remove that pet. Well, is there a way, can that pet go to maybe a family member? Can that pet, so that person can still see that pet and know that that pet's okay, or is there some other substitute for that pet? So it's just not, it's not just saying, well, you have to stop this, this, and this. You have to give the asthmatic patient options. What are choices that we can make that, one, can protect you, but still meet your personal goals? And that's very difficult at times. That's where, the asthma educator needs to really pull back their shoulders and use a lot of different methodology to achieve those type of outcomes. So the primary goal for asthma patients is preventing long-term chronic symptoms that interfere with daily living, such as coughing or shortness of breath during the night or exercise, and maintaining lung function near the personal best. So really, you're not, your goal is not to get rid of asthma. You're not going to be able to do that. So I think that's very, very important from the beginning to make sure that you make it very clear that what you're going to do is not getting rid of your asthma. We're just going to try to make your life as best as possible with asthma. We're going to try to hopefully be able, you be able to do 90% of the things you want to do without being limited by the asthma. You're going to be able to get good night's sleep without asthma waking you up. And we're going to hopefully prevent you from getting to, having to seek medical care, especially emergent care, and we'll do the best we can by trying to give the most inexpensive drugs with the most minimal side effects that we can meet your needs, okay? But again, I think it's important to make sure you make it clear to the patient, you're not going to get rid of asthma. Asthma is a lifelong disease. It's a chronic disease, and we're going to do everything to minimize its impact on you. And if done correctly, a lot of patients with asthma are very, very functional. They live very productive lives, and they have minimal interference from their asthma. So the rule of 10 is the rule of 2 is a guideline for managing asthma symptoms. If person needs to use their quick relief rescue inhaler more than twice a week, or they wake up at night due to asthma more than twice a month, they should make an appointment with a healthcare provider, because you should not, if your asthma is well maintained and you're using your controller medications correctly, you should not have to use your minimum, you should not have to use your rescue inhalers more than 2 times per week, or wake up more than twice a night. Now, one of the things is, if you're waking up at night with, quote, asthma, you have to rule out, and that's why the appointment with the healthcare provider is, does the patient have GERD, and are they having silent aspiration, which is causing a reflux bronchoconstriction? So when you look at the GINA recommendation, is when you look at level 1, if you have to use your inhaler more than twice a week, that's considered to be uncontrolled asthma. All right. So again, that doesn't sound like, wow, that's really a lot of bad. But the bottom line is, in well-controlled asthma, you should not have to use rescue inhalers at all. So that's where the rule of 2 comes from. So again, the idea would be, if you teach the person that has asthma, that says, hey, look, if you're using that rescue inhaler more than 2 times in these situations, let's talk. Let's talk and make sure we're not missing something. Maybe you're being exposed to a trigger that you're not aware of, or maybe there's something else, like you're gaining weight and obesity plays into this. So I think it's important that we teach we teach the asthmatic to understand that even subtle changes in baseline levels is somewhat of a concern. So one of the problems we have is there's when we have students that have asthma, that often they're in an environment that they can't control at all. So when you're in school, you're kind of at the mercy of the school, all right? And obviously, if you have students, young children, school age children that have uncontrolled asthma, there's going to be several things that are going to be consequences of that. Is they're going to miss more school. They're going to have more poor academic performance. They may feel more depressed about that. They may be very their ego may take a very bad hit on that, and it's because they're worrying about breathing instead of trying to learn the 50 states or the vocabulary or something like that. So again, those are things we have to look at. If we have a student in school, and this is what's important with school nurses and other teachers, if we have someone in school and we have a student that's coughing all the time, or they seem to be having trouble breathing, one, we have to recognize that, and two, realize unless we clean that up, the student is not going to be able to learn as other students do that don't have the same problem. It's important that schools understand asthma. It's incumbent upon administrators, principals, teachers, obviously school nurses, that they have a good understanding of asthma. They should be educated with asthma, and they should have mechanisms in place if a student develops an asthma attack. And the goal should be look, you have asthma, that's fine. That shouldn't be a barrier to learning, long as we get it under control. And a comprehensive plan and looking at the medical management of the disease and avoidance of environmental triggers. So one of the things that I would say is if they're going to do a thorough plan of a classroom, it should be done at the end of the school year, not at night when students come back in, or Sunday night when the weekend is over and students start on Monday. It should give time for that, and there should be enough ventilation. And we got to be aware that if we have a lot of classrooms now have pets, and they have a pet, that asthmatic child should be guarded against that pet, or maybe try to get a pet that doesn't have danders, or something like that, like an iguana, versus maybe having a guinea pig or something like that. But the bottom line is that it's important that asthma is well recognized in schools, and school administration does everything it can to minimize the effects. And again, you understand that children, even though you can have a pristine household, so a household that is very free of asthma triggers, but during the school year, your child is going to spend, basically a third, to 40% of the day in that environment. And then you also have to worry about if they go to childcare afterwards, what's that environment is. So you could just go from one plethora of triggers to another gamut of triggers to another cornucopia of triggers, because if no one understands that what they're doing in their environments and how their environment is set up can be a problem for asthmatic children, they're going to, the child's going to be unfortunately affected negative about that. So it's very, very important that schools understand asthma and what they can do to prevent it, asthma attacks. So, again, asthma management priority of school. There's organizations out there, and look at, so each day 1 out of 5 Americans occupy a school building. Obviously, majority of those occupants are children, but we have to think about teachers too, custodians, cafeteria workers. They all could have asthma too, so we have to, that's only children. And environment asthma triggers commonly found in school buildings and cockroaches and other pests. I mean, there's a lot of traffic going in and out of schools, so it's very hard to keep them, sterilely clean. Mold resulting from excess moisture in buildings. Some of these buildings are extremely old. They have very poor air filtration. A lot of them have antiquated type of heating and air conditioning, and all those factors play into that. Danders from animals in classrooms, and we don't even think about that. So Johnny, who sits next to Jane, okay, has a German Shepherd that sheds tremendously, and when he comes in, it's the danders from his clothes go to cause an asthma attack on Jane, even though she doesn't interact with the actual animal. The animal's danders are on one of her classmates, which then allows that type of transition into a trigger at this point. So again, when I go back to the mold, I mean, when you're looking at inner city, like when you're looking at Philadelphia, New York, Chicago, some of those schools are hundreds and hundreds of years old. And unfortunately, it's very hard to keep them clean. It's very hard to keep them coated properly in the sense of being able to have the correct type of, air filtration and duct cleaning and stuff like that. And a lot of these schools don't have money. Okay, a lot of the schools really struggle with money. So what are the priorities? They're trying to find teachers, they're trying to find workers, they're trying to, struggle in an environment that sometimes is Dalton. So trying to clean the schools as frequently as they should and worrying about all these different factors may be low on the list, unfortunately, but is a big problem for the kids and the parents that have asthma. Another one that we've seen now, secondhand smoke and dust mites are known as environmental triggers found in school, kind of thing. Unfortunately, when they get into like teenage years, there's a lot of smoking, there's vaping, there's cannabis use. So as they become teenagers, they could be hanging with some of their friends who are smoking, and that secondhand smoke, whatever is being exhaled, can become a trigger too. So again, the asthmatic child has to understand, or teenager has to understand, how to choose and pick friends, which is very difficult. Look, I mean, this is not easy stuff. This is why being an asthma educator is a very challenging type of position, because you're dealing with many variables here. Many variables. How do you tell a teenager, one, not to smoke, two, not to vape, three, not to use cannabis, and then secondly say, well, you know what, you gotta be very careful hanging around with Ken, because Ken smokes a lot. That could cause your asthma. Okay, and then we talk about unvented stoves or heaters, chemicals, cleaning agents. I mentioned that. Perfumes, like a teacher might come in and wear perfume, or some time of aftershave lotion. All right, pesticides. So here we're trying to get rid of the cockroaches and other type of triggers, and now we bring in another trigger that this can be very, very debilitating too. All right, so and different type of aerosol sprays used. During COVID, everybody was using that bleach. Okay, shooting bleach all over the place. We at the gym, everybody uses bleach wipes, and I'm wondering, man, what's this bleach wipes? What's this doing to our environment, and what's this doing to the air? Yes, we want to kill the COVID virus, but at the same time, we don't want to, cause asthmatic attacks or cause injury to our airways or our skin. And then you have other things. Now you talk about so kids that are waiting for bus and ride on bus, you can get the smoke and the exhaust coming from bus. Everybody can see that. And children with asthma that are on sports teams, they can get triggers. If they're playing soccer, you can get, if the high pollen counts out or something like that, then cause you to get a trigger. Or if it's very damp out, like, you're playing soccer and it's the end of October, November here in the East, it can be very damp. All right, and that can cause asthma. Or if you're playing in very hot, humid weather, it can cause. So even though we encourage exercise for asthmatics, we have to be very, very careful that the exercise itself isn't where the exercise is being done is not also a form of, enhanced triggers that can cause it. So, again, and there's ozone-free days in the sense that I know here where I live in near Allentown, Pennsylvania, there'll be days where they're called ozone alert days, and they actually recommend children in general do not go out and exercise or limit their time outside. And those that have asthma should not go out at all. So again, to keep aware of what is the weather outside, what is the forecast, predicted, things like that are very, very important to prevent these asthma attacks at schools. And, again, you talk about environmental tobacco smoke, pests, voles, dust mites, and animal danners. So here's on the left-hand side are triggers found in school, and what are the management tips for schools? So schools should eliminate exposure to environmental tobacco smoke. Well, most schools don't, they have no smoking policies in school, but it's after school and off the school premises that becomes a problem. Okay, use integrated pest management to prevent cockroach, pests. Store food in tightly sealed containers, place dumpsters away from the building. Simple things like that to make sure that we don't foster an environment for these pests. Clean up mold and moisture, leaks and moisture problems. Again, if pipes are leaking or there's, the windows are not sealed and there's a lot of moisture that caused because of the cold outside and the warm inside, and then that drops and becomes mold into the window seal. It's very, very important to get that cleaned up. Reduce dust mites. Again, make sure that you vacuum with certain air infiltrations. If you're using stuffed toys like at a daycare, make sure they're cleaned with water and detergent and a certain amount of temperature and hot water. And then again, really, I guess, it's nice to have a pet, all right, but make sure that that pet is away from sensitive students and away from ventilation systems. So what is something that's supposed to be very fun doesn't turn into something that ends up being a negative event. So again, school strategies, they look at asthma education for all. Ideally, the whole school staff should know the basics about asthma. They should be taught how to respond in an asthma emergency, and they should understand basic, asthma should be taught in health classes. So if the student is in school and they're seeing, and they're part of health class, or, I'm not sure what the term is that for today, but there should be, so everybody, all the kids should learn at an early age about asthma and understand that some of their friends may have this disease and their friends are not, abnormal. They just have a problem that, that they need to take care of. And so when they're using an inhaler, it shouldn't be looked at as some kind of funny behavior. It should be looked upon as behavior to help, your friend, your co-student there. Again, there should be school health services. There should be nurses there. There should be, again, if the student has, asthma, the student nurse should have the student's asthma action plan on file, so they know what is expected from that student and when to worry with that student's breathing or level of distress increases and stuff like that. So it's very, very important that a read copy of the plan to the school and the school nurse, and then, make sure the teachers understand that this student may periodically have to leave the class to use their inhaler, or they may see the student use the inhaler, or they may have to take certain medications. So if they have to take prednisone, prednisone sometimes changes the mood. So the child's mood may change, and the teacher needs to understand that today that student may be a little bit more edgy than they normally are because they're taking prednisone for their asthma. And then make sure that, the healthy hair is as good as possible. Make sure the child's medicine is stored in an appropriate place, that it's not lost or hampered by other students. And if there's remodeling done or construction, avoid, You have the student that has asthma, avoid that. Make sure there's barriers up there so dust can't fly from the construction areas. And then, make sure that, the school, the parents and the student are all a team in this. It's not just the patient, it's not just the student, it's the whole team approach. So as an asthma educator and looking at educational strategies, it cannot be stressed enough that you have a triangle where you have patient, you have family, and then you have, may it be school, provider, whomever, and that needs to be a complete triangle that everybody, one, is working together to optimize care of the patient, and two, the communication is free flowing. It's multi-directional, not unilateral. And we want to talk about safe physical activities. All children need exercise. A child should be encouraged. But again, I talked about this beforehand. If the weather outside is not good, it's not conducive to asthmatics, that asthmatic child should not be taken outside. The child should be able to maybe exercise in a cool gym or something like that. And maybe understand that the child, if they have like cold air induced asthma or exercise induced asthma, that child should be able to take a time out, take their medication so they can interact with the rest of the group. And then again, cooperation, community support. Okay, it does behoove that at PTA days or open school days that there is information about asthma, and realize that there's, so everybody in the school community understands that asthma, one, is a common disease in children and school-age children, and two, what to expect, and three, how can they help in this process. Because again, we don't want to ridicule children that have asthma, call children that have asthma weak. We don't want to mock them if they have to use an inhaler. We want to encourage them and, kind of foster them to the best that they can be. And again, an asthma action plan for children. This is, again, very commonly used in the sense this is a 4-tier, a lot of them are just 3-tier. So again, when you're green, there's no evidence of wheezing, can play and exercise without cough or wheezing. They're not using their reliever, puffer, and they're not waking up at night. So this is what our goal is. So as an asthma educator, we want to try to optimize this goal. And then when the individual gets unwell, they're starting to cough, they feel tight, they feel like that's increased asthma with a cold, they're getting a cold and they're waking up at night. So this becomes concerning. So at the bottom there, it tells you what you should do. Use that, instead of using a rescue inhaler now, use that inhaler more commonly. Then if it's severe, all right, where, more than 3 hours they're wheezing, they're sucking in around neck using accessory muscles, okay, they should call a provider and decide what they should do. And then the school nurse should understand if we have an acute asthma attack, what are the danger signs of acute asthma attack? A child that can't breathe and are using an inhaler all the time, they're cyanotic, they're not able to talk, they look very, very scared or exhausted. It's very, very important to get that child to emergency room as soon as possible. So again, 1, every parent, 2, every school nurse, and 3, every school, even the teacher should have an idea of an asthma action plan for children, because being proactive will be life-saving in certain scenarios. And here's another example of it. This is it shows a kid with a soccer ball. So this is a Massachusetts action plan, which is very easy for everybody to understand. Green is great. It's just like you go and you're going. Yellow is be careful, okay? And the red is, hey, we're in a problem. So it's just like a stoplight, okay? Green, we go through it. Turns yellow, we gotta be careful. And if it turns red, we have to stop. So that's the kind of ideology. But as an asthma educator, it's very important that you sit down with your patient and you go through this step by step so it's clearly defined, and then you can write in the appropriate information on their medicines, how frequently and how often. And here's another one. This is from the Illinois public health system. So you can see that there's different types of asthma action plans, but it's very important that every child has an asthma action plan, and every asthmatic should have that in general. So let's shift our way to adults now. So that was worrying about children. So one of the biggest challenges is when you're going to, children, they don't quite understand, and teenagers peer pressure. Now you get to the adult, and the adult's you gotta prove to the adult what you're telling them, one, pertains to them, two, will make an impact in their life, and three, it's something that they can help solve themselves. So Malcolm Knowles, who's considered to be the father of adult learning, looked at 4 basic principles of adult learning. Adults need to be involved in the plan and evaluation of their instruction. So right from the beginning, if you're going to try to talk to adults, may it be in, Spanish, English, French, whatever, you're going to need to involve that individual. You're not going to be able to tell somebody else to tell them what to do. They want to know what they need to do in order to help themselves. They need to experience things. They need to, realize that if you're telling me I need to take a steroid, and in the past I didn't listen to you, and this was the result of not doing this, then this is the experience I have. Both positive and negative experiences provides the basis of learning experiences. Again, how will this affect me directly as an adult? Well, if you take this medicine, you'll sleep better. If you take this medicine, you're going to miss less work. If you take this medicine, you're going to be less irritating to your wife or girlfriend. Okay, so they need to understand how's this, if they're, this will help you get a promotion, a job, because you'll be able to study and show that you can put in the long hours that are necessary. And again, they don't care about all the minutiae of information. They want to figure out, how can I get my asthma better? How can I sleep through the night? How can I stop coughing? How can I go hiking with my friends? How can I stay up at night without paying for it the next day? These are the different things that you're going to have to try to convince them, because they don't want to read oodles and oodles about beta agonists and cyclic 3,5-AMP. That's interesting to us as caregivers. They want to know this medication is going to open up their airways, and open up their airways is going to lead them to a path of success, because they're not going to wheeze, they're not going to cough, they're not going to be short of breath. So these are the very, very important facets of adult learning that you cannot forget when you're dealing with individuals over the age of 21. Again, components in adult education programs include information about airway. And again, you've got to show them ways they understand. Now, granted, as I get older, more adults know a lot about computers and are very literate when it comes to the internet, using apps and stuff like that. But if you're dealing with someone who might be in their 70s, you're going to maybe have to go step back and use information they can access or understand. Books, pamphlets, handouts, maybe even flip charts, CDs, something they can listen to in their vehicle when they're going back and forth. Okay, so giving them a bunch of apps or a bunch of high-tech computer information may be problematic. One of the things that I failed to mention that's very helpful with children is having interactive asthma video games, where you actually have the player, the asthmatic, trying to destroy the allergens and trying to gain levels in the game. All right. See, that's not going to work with a lot of older adults, and maybe with younger adults. Don't get me wrong, because a lot of younger adults are much into video games and that. But my point is, you've got to use a strategy and a methodology that is salient to the individual that you're dealing with and the age group that you're dealing with, because it's very, very important that you gear that education to, one, that they can understand, two, they can access, and three, in a way that they understand how it's going to help them. Again, description of the rationale, correct use and side effect, preventive medications and bronchodilators. And they should have a return demonstration. This should be done with all asthmatics. You can do it with children too. Is that if you show them the inhaler, that should not be the end of the education. The education should include them using the inhaler and showing you how they did it. And they should show you that the next few visits that you have with the asthmatic patient. Because again, as I've alluded in other presentations, meter dose inhaler or DPI are the most common ways that outpatient asthmatics take their medications. And there's a plethora of mistakes that are made with those steps with those. So for example, there was a study out of Chicago that showed that there are 10 correct steps in order to use an MDI correctly. The first one is you take the cap off of the MDI. 5% of the patients that are seen at the asthma clinic in Chicago didn't even take the cap off. All right. There was a great video I saw one time where, there's a lady, Dr. House was showing, had given a patient an inhaler and they weren't getting better. And he asked the patient, show how they use the inhaler. And they squirted at their ears like it was some kind of perfume. So it's very, very important not to just, show them, but they need to do return demonstration and show you that they can actually do this. And most of the time we recommend that a spacer should be utilized with an MDI to maximize drug distribution. So Breathe Well, Live Well Guide is a self-study telephone counseling in-person educational sessions that is offered by the American Lung Association for adults to have asthma to try to take control of their asthma and feel better. And some of the topics that are in this management program is understand your asthma, building your asthma support team, taking asthma medications, using tools for daily self-management, and following good health habits like not smoking, losing weight, and avoiding triggers. So these are programs that are out there that are very helpful. They're geared towards a fifth grade education. So most adults should be able to understand, one, the concept, and two, the verbiage that's being utilized. But as an asthma educator, there is a whole cornucopia of different types of resources out there that can help optimize the outcomes of the asthmatic patient. The Exhale program, I think, is pretty neat. Each letter stands for part of asthma management. The E, education on asthma self-management, extinguishing, smoking and exposure, and getting rid of exposure to secondhand smoke. Home, visits for trigger reduction and asthma self-management. A, the achievement of guideline-based management. Linkage of coordination of care across settings. And again, that's very, very important. I mentioned this before. You need the triangle of communication, which is continually flowing, okay? Maybe it's a self-propelling circle, whatever you want to use, but everybody got to be communicating. Everybody has to understand in this process what are the expectations, what are the goals, and what are the barriers. And then environmental. Policies or best practice to reduce asthma triggers from indoor, outdoor, or occupational sources. So that's another program called the Exhaled program. So again, as education on asthma self-management goals is improve medication adherence among people with asthma. So these are the goals that are set by the American Lung Association. Reduce asthma-related emergency room visits and hospitalizations, decrease missed school or work because of asthma, and reduce health care costs. Asthma costs a lot of money, not in the sense of just treating asthma, but also days lost at school, days lost at work, and loss of productivity. So think about this. A child with asthma gets sick and has to stay home. A parent who works has to stay home. Okay, so there's lost learning, there's lost wages, and there's lost production for the economy. So it has a cyclic effect, not just an individual effect. And again, the health costs are very, very expensive. So again, these are asthma action plans. That's part of the whole process. And the question is, does asthma educational strategies work? So as we finish up this presentation, is this all worth everything you've been listening to for the last 50 minutes? Does this make differences? Well, based on the British Medical Journal 2022, that effective asthma education on outcome is that those that were educated compared to the control group that really was just, your average type of, education asthma, those that attended asthma action programs and management and were well educated had 31%, which was, clinically significant. The asthma group had lower clinic visits and hospitalizations. And this study was very, very, very positive in the sense that when you educate parents and children about their asthma and teachers and other caregivers of these children, the amount of hospitalization, ER visits decreased tremendously at this point. So education in the hospitals was associated with reduction of clinical visits. So it's very, very important, and there's evidence to show that a proper asthma education will improve asthmatic outcomes. In 2015, that Louis Perret in the European Respiratory Journal showed that if you educate, during family medical clinic visits, that you educate the asthmatic that there is a significant reduction in unscheduled visits, physician visits, and also very important, more appropriate medication use and a greater adherence to the asthma action plan. And the emergency room based automatic referral process, meaning that any patient that came into these emergency rooms with asthma attack received a certain amount of asthma education, which then tremendously helped in preventing more emergency room visits. So I know what we do at our institution is whenever we have an asthmatic come in the emergency room or they end up being admitted into the hospital, they automatically have a consult placed for an asthma educator like myself to come down and assess the asthmatic, try to figure out what we can do better to prevent this asthmatic to have an uncontrolled asthma attack, and see where the deficiencies are. I just worked recently with a young woman in her 30s, and again, she knew what she had to do, but she didn't have the financial ability to do it. So I worked with the case manager to see how we could make that reality. So hopefully this was someone that knew their disease. This was someone who knew what they should do, but they just didn't have the financial ability, and they ended up having a fairly significant acute asthma attack that required 5 days of mechanical ventilation. Very nice young woman, just in a very bad social situation. So we have to understand this. So being able to recognize the asthmatic patients, an asthmatic that comes in for ED visit or is admitted should have asthma educator there trying to figure out how they can prevent that in the future. So in conclusion, asthma education is effective in reducing exacerbations and hospitalization. It's well documented in literature. But you, as an asthma educator, must understand and tailor individualized, specific educational strategies to maximize learning. And again, you have to tailor the learning to what I would call your client in the sense. And there are significant barriers in asthma education learner. From group diversity, cultural norms, to educational levels, to physical abilities, obviously economic, socioeconomic factors. There's a whole plethora of problems, as I say, in that, and you as an asthma educator need to understand how you can get through these barriers and how you can optimize understanding and care for your asthmatic. And really, even if you're not a quote certified asthma educator, every respiratory therapist and every nurse should be an asthma educator, meaning that they should understand asthma because it is very commonly seen in the hospital environment, especially if you work in emergent care or urgent cares, those type of healthcare settings. It's incumbent that you have a fairly good understanding of asthma, both the acute and the chronic symptoms, and obviously the most emergent symptoms when you have to, utilize emergent care. So I hope you, learned something during this. I think being an asthma educator is very rewarding. As I said, I've been one for a decade. I think can really make a difference. You can really make a difference in an asthmatic patient. It's not always easier. Sometimes you have to, jump over some fences and climb some hills. But it's very rewarding if you can prevent, such simple things. I remember one of my friends had asthma, and as I was learning more, I got that person on a biological drug that has changed that person's life. They are a whole different person because they can actually live their life. Biological drugs have their own problems, but it's been a life changer for this individual, and they were not aware that these drugs were available. In the last few years. So again, thank you. This is my email there. This is my telephone number if you have any questions. And again, take care and thank you for having an interest in asthma education. These are the references. I would suggest that if you want to learn more about asthma education or the disease itself, I think anytime you want to learn about asthma, you go to the GINA, the Global Initiative for Asthma. It gives you a great overview of the pathophysiology, of the different medications, the triggers, and then a whole gamut of educational strategies and outcome data with those strategies. And even the panel working group is another one. So these are 5 really good references that really could widen and enhance your knowledge of asthma education. Again, take care and good breathing.